All right. Hi, everyone, and thank you for joining the Grant Focus Mental Health session today at ICON. Some of you may have joined us earlier in the year for a conversation focused on solving for mental health in cancer care. And at that time, we discussed three different things: rebranding mental health, connecting to others like me, and care plan implementation. So today, we hope to take those discussions a step farther. Our goal for today's session is to narrow down what a potential Livestrong investment could solve in this area. So what should be a part of the solution? What shouldn't be a part of the solution? And how can these ideas be implemented in real time? So to lead us in our discussion today, we have Lisa Kiefaver. Lisa has spent over 20 years as a clinical social worker and narrative therapist. At the age of 40, she lost her husband to cancer unexpectedly. As a result, her mission to help families, communities, and cultures support grief is her life's work today. She is the CEO and founder of Reimagining Grief, and we are honored to have her here today. So Lisa, I'm turning it over to you.
Hi, welcome everybody. It's nice to see some faces and some names. And I'd love to tell you a little bit about myself, but I'd just love to know, maybe in a word or two, since we're such a small group, if people could go around and say like kind of the orientation you're coming from as a professional or a person experiencing cancer or a care provider or all three, just so I can understand kind of the point of view of who's in the room. Maybe I'll call on people and you can unmute yourself if you don't mind, just to keep it orderly. So I'm going to go clockwise on my view. I don't know if this is your view. Abigail?
Hi, I'm Abby, and I'm actually a part of the Livestrong group.
Okay. Hi, Abby. Thanks. And maybe Nick?
Yeah, I'm a Livestrong volunteer also, and I'm coming from a cancer caregiver role for my wife, and I was also a cancer caregiver for my father when he had brain cancer about 15 years ago.
Okay. All right. Thanks for joining us today, Nick. For those just joining, I'm the host, the moderator, Lisa Kiefaver, and I'm just asking people to say in a few words kind of your orientation for why you're here today, what your passion is: patient, caregiver, etc. So maybe Heather?
Hi, I have been involved with Livestrong for a long time, since my own cancer diagnosis, and have seen and tried to help plenty of family. And then Lisa, I was looking at your website the other day, and I'm also just very interested in some of the work you do for various reasons, some related to cancer and some not. So I might reach out to you afterwards.
Yeah.
And I will, while I have sorry for everyone, I unfortunately can only join for the first 30 minutes. So please don't be offended when I drop off. And I'm very upset because I'm very interested in your session.
Well, it'll be recorded. It's being recorded.
Okay, great.
So, yeah.
Great. Thank you.
Thank you. Simon, would you mind just sharing in a few words what's bringing you here today for this conversation?
Yeah, hi, I'm Simon Davies. I'm the Executive Director of Teen Cancer America, and we're developing programs and services for young people in hospitals around the country, and helping those hospitals develop specialist services for this age group, which is underserved, and they don't really fit into pediatric or adult care. So that's really our raison d'etre. And of course, mental health is a big issue for those young people, and that's why I'm joining the session.
Awesome. So glad you're here. Thank you so much. Jillian, would you mind sharing a little bit about what brought you here?
Yeah, hi, I'm Jill. I'm also work for the Livestrong Foundation, and I'm just big on mental health. So this is both related to me, so I'm excited to hear.
Awesome. Okay, thank you. And last but not least, I hope I'm pronouncing your name right. Srini?
Yeah, you got it, Lisa. Yeah, I'm the founder of a digital health company, and looking to see how we can up-level cancer care and obviously mental health, being top of mind for not only the patients, but also on the caregiver side. So happy to be here. And like Heather, I can only be here for just under 30 minutes. I have another call, but I'm glad the session's getting recorded.
Yeah, awesome. Well, thanks so much for joining us today. I'm going to share a little bit about kind of my involvement in the last session. I'm going to tell you a little bit about me and just some things that I've been thinking about since our last session that maybe will help set the tone a little bit more for our conversation, but I'm just a convener. I'm just a moderator. So I really want to invite other voices into the room, but I'll probably spend the early part of it just maybe setting the stage a little bit so that we can have this conversation and just the framework from which I'm coming at this conversation, but mine is not the only viewpoint. So that's why I wanted to know that we have providers and educators and family members and all kinds of folks in the room and different populations like the teen population. As KK mentioned, I'm a social worker. I worked in lots of different settings, crisis intervention, foster care, public housing. I am a previous founder of a nonprofit in Austin, actually called the CareBox program that helps cancer patients. I'm also someone who watched a husband become a completely different person in the medical system, attribute it to just declining mental health, only to find out 2 weeks before his death that he had a grapefruit-sized brain tumor in his, that had shifted his brainstem. And so, and even as an advocate and somebody who's articulate, we couldn't get anybody to take us seriously. So even thinking about the fact that it was wrongly labeled mental health, I still care very much about how we think about, so that's kind of like the personal orientation from my experience, but also, of course, as a provider, I do run Reimagining Grief, which my mission is to change the narratives of grief one conversation at a time. And I think that applies really to this broader conversation we're having today, particularly of the 3 subject matters. I'll be transparent, that's interesting to me, is thinking about rebranding mental health because language matters, but not just in the marketing campaign or in the language, but just really because our language is a reflection of our beliefs, but our language also reinforces the beliefs that we have about certain topics, including mental health or mental well-being, which we can talk about today. And I'm happy to answer questions. But some of the things that I've been thinking about, whether we're talking about sort of the work of rebranding mental health or connecting with other patient experiences like your own, or even care plan implementation, is it has to start with a kind of reframing of what we all know to be true. I think we're all coming at this notion of not just mental health, but even the place that mental health has when you think about cancer care largely. And we're coming at it, a cancer care system largely, which is really a medicalized system with experts whose job it is to fix us. And I say that because I think that's a really can hold real opposition to the notion of that it creates this binary notion that we are sick or well, and that there's not some place in between. And I also think that doesn't really attend to the fact that we all have lived experiences and expertise, and we all have, in addition to having mental challenges, which might, or challenges in our mental health, which might be one way to say it, we also all come with a lot of resources. And so oftentimes what happens is we're not even if we don't even have the conversation, then we're not really noticing. If we don't name it, we won't notice it. If we don't notice it, we won't know what steps we can take to help appease. So there's a couple of things that I've been thinking about as far as this reframing and helping people connect with other patient experiences, particularly in the mental health journey. And the first, I think, would be just naming it. So naming that, and I don't mean naming like giving it a brand name, although that's fine. I don't actually particularly have a problem with mental health. I think it's really our well-being is really how we should be thinking about how we show up for patients in general. And the ways in which we kind of cut off our heads from our bodies and assume that mental health is somehow disconnected from our physical well-being is problematic. So whatever narratives or language we use, I would really like us to think about kind of whole person care. That's not just a disembodied care to our parts. And when I'm speaking, I do worry sometimes that people think I'm sort of down on doctors or nurses or care providers. I'm not. I think it goes back to, which is part of my proposed solution, the training that folks get. And of course, we want our doctors, our brain surgeons to be really expert in that thing that they do when they open up someone's brain or someone's liver if they have liver cancer. And we have to think about how we create a shared humanity, how we understand the people, our patients, our loved ones, our whole persons. We are whole people, and that our mental health and physical health are not two separate things, that they coexist. I've been thinking a lot about the fact that we need to think about the fact that we all have mental health. We all need to attend to our mental health. And the reason I'm naming that clearly is I think we need to recognize and honor the fact that providers, when they walk into the room, and again, I'm saying oncologists, doctors, nurses, whoever, even social workers who are working on care teams, show up with a kind of expertise and authority that's inherent in the room, whether they name it or not. And sometimes without acknowledging the fact that we as providers are human in the room, because we've drawn these expert boundaries, we further stigmatize anybody's challenges or resources and sort of depersonalize our connection. And when people are experiencing something that makes them feel vulnerable, like a cancer diagnosis and challenges in their mental well-being, we're much less likely to be open to seek questions, et cetera. So I think just the importance of naming and normalizing that is an experience that we all have. I think the normalizing piece goes a step further, and I'm thinking about this when we think about how we communicate, which is kind of the rebranding aspect of our work today, but also how we connect patients with other patients, which is to name and normalize the fact that any challenge to our mental health in the wake of a cancer diagnosis is a normal response. So our bodies, thank goodness for our body, was designed with a nervous system to respond to danger. And of course, a diagnosis, any kind of cancer diagnosis is danger, but so is an uncertain future and a story that has been shredded. And so when our body goes into these fight or flight or freeze responses, which is not unusual in the wake of some kind of diagnosis and ongoing harm to your body, whether it's surgery or chemo or radiation, it's important that we, the providers, we, the patient, we, the caregivers, understand and normalize out loud. Of course, you might be having challenges. This is your body's response to this danger, to this threat, to this unknown thing. And again, kind of helping soothe everybody's perspective that this is normal. And so if this is a normal response, like the side effect of chemotherapy, like losing your hair, like any other side effect, then somehow we're going to help destigmatize both the doctors or nurses, and I'm just picking whoever, the providers maybe own beliefs and stigmas about, I don't want to bring this up. You would bring up hair loss. You would bring up weight loss. You would bring up nausea. So normalizing that as a normative stress response, I think can help both on the provider end, the caregiver end, and the patient end, even just begin to open up to a conversation about what would mental wellness look like for you and for the patient. I also think when we think about, and I can't say because I am not a doctor, but when we're thinking about doing some kind of assessment, when we're at the point of diagnosis or developing a treatment plan or a care plan, we have to remember that people have lived lives that come in long before we see them in our practice. So while there is a normal response to be challenged to your mental well-being in the wake of a diagnosis, we also need to understand that those folks come to us maybe with histories of trauma, other mental health challenges and issues, and how do those intersect? And most as importantly, we need to think about what are the resources and skills and resiliencies that those people navigated when they had mental health and wellness challenges in the past before this. Because when we're coming up with a treatment plan, we might want to first ask the patient, what have you done to attend to your mental wellness that's worked for you in the past? But if we don't show up in the full humanity of understanding that an assessment needs to not just include the body parts of the person, but a full, rich resource understanding of what their capacities and resiliencies are, I think that's really, really important. And part of that is really understanding that, helping the provider understand the privilege with which they walk in that room, that there is already kind of a power differential. And so it's not just enough for us to deliver words, but we have to really shift our kind of collective understanding about the normalcy and the importance of attending to mental well-being. So there's kind of 4 ways I think about this is kind of setting the tone. So there's like the mood and the attitude, if you're thinking about it from like a marketing or branding. So what is the energy that we bring into any patient room experiences, to our billboards, to our literature? What is the mood? Is it compassionate? right? Or is it sort of diagnostic and transactional? And when we're talking about something that's been historically stigmatized, which mental health is, it's more important than ever to really think about setting the tone. Again, there's also the changing the narrative. So when we think about how we discuss or help patients, family members, et cetera, understand what might be some of the challenges you experience in your psychological, mental, emotional health and well-being, we need to think about how we use the narratives, and even from this diagnostic lens. So a patient would never say about themselves, I am brain cancer, I am liver cancer. But something has happened in the mental health world where we say, I am depressed, I am anxious. And I parse that out because I think it's really important when we think about these labels, or when we even think about attending to mental wellness, we need to think about the power of the narratives, both as the provider and the patient, so that we don't forget the other layers of our identity, the other capacities, the other resources that we bring to bear, even when we're facing something challenging, right? Like a lymphoma or some other cancer diagnosis. So thinking about I have gives us some space to think about how we might heal and attend and implement some of the resources that hopefully we're going to talk about today. I think from a linguistic standpoint of view, when we think about issues, you're having issues. Issues is kind of stigmatizing. I think if we think about the challenges that we might face, just like we might face challenges of sleeplessness and food and maybe loss of bladder control, we might face challenges around our emotional stability, around our stress response. So thinking about those narratives. Again, I think we have to find common ground as the third idea, like the we. And this goes especially, I think, when we're thinking about connecting with patients like me, is how do we help normalize that we all experience these challenges when we're faced with something uncertain, when we're faced with the threat to either our actual lives, in terms of, death and mortality, but also just to the story of our lives that we knew in the before the diagnosis. I think finally, and then I'm going to maybe shut the heck up so that I can invite some more conversations. But I think another thing we need to think about when we're thinking about mental health and cancer care is focusing a little less on the issues and the challenges, not that we don't need to name them, but really focusing on understanding what are the outcomes, and what are the outcomes that the patient wants or the caregiver wants, right? So what is the end game here when we think about attending to somebody's mental health? Is it peace of mind? Is it a sense of agency? Is it control? Is it calm? Is it tools and resources? So just really helping us show up in every space, thinking about what might be the outcome or the end game. As just throwing my hat in the ring to think about some of the things that might start our conversation in terms of maybe what might be those potential investments, as KK said, about how we go about. To me, one of the places I think would be important to start would be training providers of cancer care, particularly in this subject, because again, I don't think these are typically the kind of issues that are brought to bear when we're thinking about the medical institutions and training sessions. So really helping providers understand the normalcy of any kind of mental challenges response, again, thinking about the stress response, the importance because they're in a role of privilege of how they might communicate the normalcy of that to the patients, to the caregivers. And by the way, more than once, because as we all know from experience, your brain turns off when you show up for that diagnostic meeting. And I think we could be training providers on how we assess both the pre-existing challenges that a patient might have come in with, again, those mental health issues that they might have had before this experience, but also assessing what are their resiliencies, what are their capacities, what are the tools they already have, and how can we help use that in our prescription to help patients, their families, et cetera, attend to their mental health as they're attending to the rest. Of course, there's issues of programs that might be helpful, like referral systems and follow-up. And there, of course, could be something in the broader scope where we're really doing a marketing campaign to do this kind of destigmatizing work. But for me, from my vantage point, of course, we all show up from our own vantage point. I've been really thinking a lot about the power and the role of the provider. And if we don't help them understand how to set the tone and change the narrative and find common ground and focus on outcomes, anything we do directly with a patient or a program is going to sort of be lost in the ether, because there's power that's held kind of in the provider world. There's sort of cultural power there. So that was a lot, but that's what I've been thinking about since our last conversation. I've been thinking about the normalcy and the language that we use and where folks come from. So I'm curious, for those who attended last time or got to read the white paper, maybe watch the last video, and maybe based on some of the things I just shared, what's coming up for you when you think about where what might be the challenges that we are trying to help attend to, whether it's from your sort of unique location, like Simon is, and as doing teen programming, or more globally? What is coming up for folks when they showed up for today's session?
Lisa, maybe I'll start because I do need to drop in a little bit. But yeah, I mean, I think I agree mostly with, how you phrased everything. I'll maybe just pressure test one aspect, which is,
please.
I know the providers have a lot of power, but I think, we also have to realize that the amount of time that the patient is in front of the provider is minuscule compared to the amount of time they're outside of the medical establishment.
Yep.
Right?
Yep.
So I think the solution that we create, it does seem like, the providers and the physicians, because they're wearing the white coat, right, have all the power, but actually it's not, right?
There is so much power in our cultural narrative languages outside of that. I absolutely agree. I just also attend to, that's the first step when they're in front of the providers. Yep. That's that first step. So that's the place where I think we need to set the tone. I think that's what I meant, but I agree culturally.
Yeah. And I'll tell you, like, I mean, not to go into kind of our recent sort of family thing on my wife's side, my wife lost her uncle to liver cancer just about 2 months ago. So we spent the majority of the summer at Memorial Sloan Kettering. And, this was a gentleman who was already kind of an introvert to begin with. I mean, that's his personal nature. And as soon as he got this diagnosis, he kind of went into super introverted mode, right?
Yeah.
And what was intriguing to me is, I mean, an institution like MSK, which is, if not the top, it's in the top 3 in the country. I don't think really addressed how he kind of sort of degraded into that mental health state that he went into for about 2 or 3 months, right? Yeah. So it was really an afterthought from their perspective. So which the light bulb kind of goes off in my head. If an institution like MSK that has all the resources can identify and address that, what luck does a patient in Lincoln, Nebraska, who's going to a local community oncology practice have, right? Where it's really maybe 2 oncologists and a nurse practitioner and a receptionist, right? So I think that's where I think solutions that, we kind of build need to kind of, look at sort of reframing the problem. I'll just say one other thing is in terms of mental health from, the number of patients and survivors that, we've spoken to, the biggest challenge is right up front at diagnosis, right? And that was the case in my wife's uncle's case, where literally for about 2 or 3 months, I mean, there would be days where he would maybe speak 5 or 6 words, right? Like he was just not responding. And then the other part is after somebody's been cleared with no evidence of disease, we've heard that, people go into this, they need this mental health. So those are the 2 kind of endpoints that I think, and there's in between as well, but I think from a solution perspective, if, kind of, how do you eat an elephant, right? One piece at a time. So, right. Yeah. If you go after the initial diagnosis and maybe towards the tail end after, they're clear of the disease and we can attack the problem from both of those 2 perspectives, I think it'll be a good start. Anyway, I'll stop there and see if somebody else wanted to chime in.
No, I appreciate you helping us understand the sort of influences that are beyond the room, you know, the patient room that they're in. And I do think that's really important. I think that thinking about the intervention points is really important too. I think in the beginnings, I think that initial diagnosis, that's the setting the tone part that I was talking about a little. If we don't name it and normalize it and set the tone that this is something that we might want to track, consider, support you with, et cetera, then we've lost, you can't kind of catch up and make up for that. I do think when you're thinking about, for the particular cases where the survivor is cleared and someone is kind of in the survivor world, recognizing that even that good news they might have been holding the processing of all of their emotional, mental, psychic health until that moment. And then at the moment of clear, that's when all the waves of everything catches up. So I appreciate you bringing up that that's a particular aspect. I, of course, always think about grief because that's the lens from which I show up in the world. So the anticipatory grief and the ambiguous loss that's happening throughout a cancer journey. And even the grief that a survivor might feel because maybe they've lost some capacities or they've lost the sense of innocence or all the other things that they're thinking about. So yeah, thank you for bringing that to our attention. And yeah, thinking about those intervention points, that's really helpful, Srini.
Yep. And I think just to finish up on that, before I turn it over, I always think of it as like a feedback loop where, survivors who've gone through that entire sort of experience, and if they've recognized mental health as being something that was really important to them through the journey and even into survivorship, going back to that topic of connecting with other people like you, if they can influence people who are just starting that sort of, who just recently received their cancer diagnosis, and help influence them that, hey, mental health should be part of things that you should be considering and seeking help on, right? Because that was the missing link, and at least in our recent family experience. Like, even though this is kind of one of those things, right? If it was my family, I would have forced the issue, but it's my wife's family, right? So even though I knew some of this information, you can only sort of bring it up to a certain point. So I think it goes back to people will take up suggestions from people that they like or they know or have some similar interest in. So even if we think about the sports that we joined years ago, or the type of foods that we tried, it's all because somebody like you that maybe tried it and then said, oh, you should try this, Lisa, right? You might like soccer, or you might like Lebanese food, or whatever it is. And I think that's the same case in here. If you find somebody that that your ideas and your way of thinking resonates with, and if they say, hey, mental health should be part of your treatment, then I think you'll probably incorporate it.
Yeah, I think really kind of what we're already starting to understand is that this has to be a multi-pronged approach. We have to be changing the minds and hearts, systems, providers, patients, caregivers, because each person is going to sort of lean on the influence, or have different people influencing their understanding of that. I do think I want to throw out there, when I'm thinking about like Simon is trying to create programs, I know KK, you're involved in programs too, and not to sort of try to tackle it all at once, but something to keep in mind, even as we come up with some initial programming, is it's one thing, and it's critical and important to set the tone and name and normalize and help people start to understand that attending to your mental wellness is an important and beautiful part of your cancer journey. And if we say that and put pressure on them and then don't provide the resources or help them think about their own resources that they already have, then that's just one more burden we're laying down on a patient and our caregiver who's already burdened. So we have to be mindful that when we bring up this and help normalize it, that is wonderful. That is a first step. It's completely important. But we can't do that in absentia of actually delivering some way in which the patient feels they have the capacity to enact that, to do that. So those are kind of just something to consider when we think about programming, either in the short term or the long term. Anybody, who else would like to chime in? I know Heather had to leave, unfortunately, but.
I don't mind saying something now. Some of the things that you said, I think that resonated with me, which I think are really serious about the systemic way that we deal with cancer, whether it's young people or any age, is that it's convenient to compartmentalize people and their experiences. That's convenient for people working in the health system because it's very challenging for them, and actually to say, well, this is a mental health issue, it's a depression, it's an extreme anxiety, so let's call a psychologist in to deal with that. And I kind of think that really we have to do a lot more about empowering people working in the system to all have skills in sort of and using much more simple language. It's about understanding, it's about kindness. It isn't necessarily about being a therapist. And I think a lot of things that individuals and families, when we're working with them, we don't know what we don't know. We don't know the whole picture. And part of what we need to do is to understand better what the whole picture is and what they're going through, and enable them to be empowered to dictate as far as possible what kind of support and help they need. And the labels I find get in the way, even the term mental health itself. If you think you've got a mental health problem, then you're already on the back foot, and concerned about, whether you're going to go mad or whatever, And so I think there's a lot that we have to do to normalize in many ways what people are going through, although it's completely abnormal experience compared to their normal lives to have cancer in the first place, but to find ways of normalizing that and putting it and contextualizing it within their own experiences and their own lives.
It's a normal response to the abnormal.
Yeah,
what you're saying.
Yeah, exactly. Who wouldn't be depressed about
or anxious or exactly, sleepless.
And we would all be the same. And so I think that we have to put much more effort into that and have the people that are connecting at any level with those people to with people that are in that situation, to be able to empathize and support them and enable them to, and their families, to help dictate the type of help they need. And not get caught up on, is this depression and shall I give that person a pill? It's much more about understanding what's going on and learning about what the environment is. Quite often the stress is about the fact that, they're more worried about their children, and the impact of their cancer on the children than they are about what's happening to themselves. So,
or the financial implications of their diagnosis.
What's out there? And that's what I feel we need to have and I see that with young people a lot, because they get pigeonholed as, withdrawing or being awkward or being difficult in situations. And it's very often, it's just their way of coping. And so we have to learn what that is and how to find the touch points within that to enable us to help them well.
Yeah. Oh, Simon, I really appreciate you reminding us about that normalizing experience and across populations. Something you said that came up for me that I think resonated. And I know somebody brought up earlier, they have providers often have limited time or limited contact, and they can't be, they're expert in their wheelhouse, their, oncology or their particular surgery or whatever their thing is. But I don't think we need to expect providers to be psychologists and be therapists. I think this comes back, of course, I'm being self-clear about my own pitch but I think it comes back to reminding or training providers that the best tool that you can show up to attend to the mental wellness of both the patient and the caregivers is empathy and your humanity and your curiosity. Something you said, Simon, made me think about that, which is how are providers showing up curious and not making assumptions about the capacities, the resiliencies, the challenges, the opportunities that patients and their families are taking. So you don't have to show up and know the right thing to say. People always this happens in grief all the time. People get hooked on, I don't have the expertise, or I don't know what the right thing to say. But actually, one of the most powerful tools we can use in normalizing someone's challenges in mental health, but also helping them see what options they might have next, is to show up with empathy and to show up with curiosity. And I think those things aren't necessarily inherent. There are plenty of providers who are empathetic and curious, so please don't get me wrong there, but I don't think that's necessarily culturally, when you think about what providers are encouraged to be, I don't know that empathy and curiosity is necessarily, they're encouraged to be expert and to have the answers. And I think that's a tough one. That's kind of the rub, I think, for providers. I personally think that we're not going to kind of tackle shifting stigma and shifting resources to enable mental well-being for patients if we don't have providers showing up believing that and being empathetic and curious. So that's kind of just my response to what you said, Simon. I think that curiosity and that empathy is important. I mean, for everyone in the system of cancer care, but for sure for the providers. Yeah.
And I think that's so interesting because when I do Livestrong at school panels and roundtables, the students want to help the people with cancer, but they feel like they're not doctors, they're not social workers, like they can't really make an impact. But I always tell them the best thing you can do is listen. Yeah. And that is simple advice. We could be telling providers, you just need to create space for that grace period in your interaction with patients. Yeah. I agree with you that reworking the system and training everyone to have these empathetic, deep diving conversations is a big task.
Yeah.
It's not hard to add 5 minutes in that meeting that they're running, as you described, to have just, what are you feeling? Not how are you feeling? Yeah. And then here's what I saw on the test, and here's what you need to do at the next appointment. Where in that 30-minute window can we just add 5 minutes, for the how are you really feeling
in this moment? By the way, let's clarify, because that might change. So helping people not say, how am I feeling globally, but how are you feeling about that news in this moment? Yeah. Mm-hmm. I mean, yes, I would love to overhaul the entire medical system. However, when I said bringing empathy, inviting providers to show up with empathy and curiosity, it really has nothing to do with a specific, you need to now make 15-minute appointments, 30 minutes appointments, or 45 minutes appointment. It's really, again, setting the tone. How are providers showing up, being a human, seeing a human across from them, and thanks, Simon, has to drop off, and opening that space, whatever that space is, to just sort of be curious and to be empathetic and to listen. I say this about grief support, but I would say this is just really true about empathy and curiosity all the time. My grief support motto is show up, shut up, and listen. And I think in some ways, of course, we want to do some prompting questions, but that's really what we're saying. Don't have to show up with the answers. In fact, that's the opposite. We have to show up and ask some questions and do it with empathy, not with, because I'm trying to get to some outcome. Yeah. Nick or Abby or Jill, thoughts based on our conversation so far?
Yeah, I've written down so many notes in the last. I mean, the gentleman that talked before me, I forgot his name.
Rainey, yeah.
Yeah. I mean, he said, when you clear the disease, okay. And I can tell you from my wife's perspective and mine, even after you clear that disease, or you think you cleared the disease,
yeah,
it never stopped thinking about it. Mm-hmm. Never. Okay. So it's a constant, okay, when is it going to come back? What's going to happen if it does come back? Where is it going to come back?
Yeah.
Okay. I think Simon said about depression and anxiety. I wrote that down before he even said it. How could you not be depressed or anxious when somebody tells you you have cancer?
Yeah.
That's just.
But if we don't tell patients that is a normal response to the abnormal, then they feel more abnormal for having this totally normal response. It begets a kind of downward cycle. Yeah. I
mean, even the perspective of my dad when he had cancer in 2003, being first generation, he wasn't even first generation, he was from Italy, a little bit of a language barrier. Okay. Nobody ever said, how you feeling? Yeah. How's your mental capacity to deal with this? Anything like that. I don't know if he knew even the terminology of, what kind of mental things you might have going on. I mean, we did the best we can. Or you go to 2015, my wife had cancer. She's an RN, but even then, nobody ever said to her, and we went to one of the best hospitals in our area, Penn. very good oncologist, which she still, visits. Guy is fantastic, caring, compassionate. He listens. He's very cautious. He's never once said to her, hey, how you feel? Have you looked into any kind of mental or
supports
or things like that? She's done it. She's done it because my daughter forced her to. Okay. And I'm sure it's helped, but that was after the fact. That's only been in the last year.
Yeah.
So there's just so many things, and you have family history before you even have cancer.
Right.
Where my wife's family had, on both sides of her family, there's some mental health issues there that for years have gone on. So before you even get cancer, you might have these issues, and then it exasperates the whole thing. So yeah, there's a lot to think about here, and it's good to hear.
I know we're unpacking a lot, and I know I know we all live in this world where we want to get to outcomes. So I just want to acknowledge that some of us might feeling stressed that we're doing more unpacking than coming to solutions, and just name that and acknowledge that, but also hold space for that. I think it's important if we want to move towards some meaningful solutions to really unpack.
Yeah.
Next, a couple things you said just resonated for me. One was when we think about how we ask people, how are you doing? And particularly when you think about a language barrier or, culturally, your dad was from Italy, but also just maybe different people have different beliefs about talking about feelings, emotions, or don't have the language for it.
Sure.
Is how might we ask somebody then? We ask a patient, where do you feel in your body? Are you feeling aches and pains from the surgery? Or we ask people, but our emotional mental experience actually lives in our bodies. So what if we asked a question that said, when you think about the upcoming treatment, or when you think about the news, let's say, or maybe it's further down the line, when you think about, survivorship or the next steps, and I ask you that question, can you take a moment to notice, where do you feel that in your body?
Yeah.
Right? If you feel that in your heart, that might be depression. You feel that in your gut, that might be anxiety, right? If we don't, people might not be able to name or label that it feels any of those labels, which are problematic in themselves, but they might have a more intuitive knowing. And if we get at that, if we kind of go towards that question, then that might help people start to understand, oh, actually I am feeling anxious, or I am feeling worried, or sort of getting at that information from a different place. So, yeah.
Yeah, it was a struggle. I don't want to say struggle, but it was something that I'm sure you could tell he was depressed about it. He was, dealing with it in the way he could, but he never knew any of and nobody ever said to him. And I think if anybody ever said to him, why don't you go talk to a therapist? He would have been like,
right, exactly.
Forget it, so.
But if we normalize, so instead of saying to the therapist, how do you, I want you to feel as well as you can feel. And here are some different ways we feel unwell when we're going through the cancer journey.
Yeah.
And so how can I help you think about the different ways we can help you attend? I think something else you brought up when you talked about both you and your wife, even never not worrying, even in the, wake of being in kind of survivorship, in the phase of survivorship, is how are we asking patients? I mean, this goes back, of course, to this is sort of in a Atul Gawande bigger question, how do you want to live and how do you want to die? But how are we asking patients, what are the outcomes that you're hoping for? And it's not just the outcomes of obviously not having cancer, or still being able to walk, even if we have to do something, or still being able to pick up my kids, or, kind of the activities of life that bring meaning. But we might also think about asking questions around your emotional, psychological well-being. What are the outcomes you're hoping for? I'm hoping to feel at ease most of the time, or I'm hoping to feel resolved. I'm hoping to feel peaceful. I'm hoping to feel less anxious. We might just be doing the less of things. But if we're thinking about designing communications or programs or training, I think we need to be thinking about helping the patient first name it, but then think about what are the outcomes they might be searching for, because that might determine whether therapy is the right thing, or connecting with someone like me is the right thing, or just attending mindfulness meditation, which I'm a big believer in, to help soothe. It might be other outcomes, but we have to understand what their preferred outcome is first.
Yeah. And one of the things that helps us too, and it might not help everybody, but prayer and our faith,
Right.
and our religion is a big part of helping us deal with all this.
Yeah. And of course, so those are some of the things we're not going to know as providers if we don't ask questions. And I will step back and say, I know a ton of amazing, right there in Austin, pediatric palliative social workers and other child life specialists and folks who are asking these kinds of questions. So I'm not saying the doctor has to go into that deep dive, the oncologist.
Yeah.
But how are they setting the tone and passing along to the social worker, the child life specialist, whoever, who is going to explore, is religion a resource for you that could help you feel well and be well? Have you ever thought about mindfulness meditation? Does talking to somebody who's been there before you help? Like, they are trained more to ask those questions, and that's great, but it's got to start upstream, I think.
Yeah.
Yeah.
And I think from what I've heard, like at Penn years ago, there was kind of that, those connections, I guess, where they would have a social worker come in and talk to you and all that. But when Barb went through it, it was just the oncologist, and that was it.
Right.
So either the program just died away, or
unfortunately,
funding wasn't there for it, or
unfortunately, funding
happened.
is often not there for it, or it's one social worker for hundreds of people. So that is a systemic issue. I'm not sure that we can solve with the Livestrong. Which is why more important than even those 5 minutes of listening and being curious at each provider meeting might help. And then knowing the resources to deliver them to, even if it's not within the hospital system, it might be community resources, is so important, because not everybody's going to have my friend Rachel Carnahan-Metzger, who's a pediatric palliative social worker there, adult children's, right? They're not all going to have that time. So, Jill and Abby, I want to be mindful that and give you guys space, not that you have to, but to ask questions or contribute or challenge kind of the discussions that we've been having so far.
Thanks, Lisa. I did want to chime in, just kind of building off of what all of you have really kind of touched on, is just how mental health in general is so nuanced. I feel like specifically, I'm sure in the cancer care and whatnot, but just like KK said, just opening that space to say, 5 minutes of just engage someone's where their head is at, maybe just the small things, or do we need to give you more resources? I think those conversations are just so important, or just giving someone the opportunity, because we're not all outspoken. We're not all okay with those conversations, or even have the words to say, I am struggling.
Right.
So
sometimes in shock. So we don't even know what we feel until somebody asks us how we feel.
Absolutely. And maybe even having that, 5 minutes every time you meet with your care provider. So absolutely, I think that's in every sense, just not just in cancer, and in every healthcare situation that I've even been a part of. I feel like there's definitely not that kind of touch and go of like, just want to gauge where you're at. I think they're always focused on the big fish, and they don't, the big problem, and don't want to tackle those small things. But no, I completely agree.
Yeah. Well, we also know when we're mentally unwell, we're less likely to be compliant to the care plans. If we aren't asking our patients, like we gave a care plan, but we don't understand that they're stressed because they don't have the transportation to get somewhere. So there's providers not using those 5 minutes to ask those touching base from human to human, how are you feeling, actually has a real world material impact on the big fish that they're trying to catch, which is kind of maybe cure is the goal of that plan, or maybe just a longer life, whatever that is. So, and that's where I always kind of go back upstream. It's not just the building the time, but it's also convincing or helping providers understand how showing up in their full humanity in each of those sessions benefits the patient's, it's not just that it benefits the patient's mental well-being, it actually helps them improve their outcomes for the patient too, I think.
And I think one thing that's interesting as a community of supporters, whether you're a friend or a family member or whatnot, I feel like oftentimes people that are dealing with cancer, you know, even in the name like Livestrong, you're strong, you're always strong. But what about the days you're not strong?
Yeah.
You can be both. You can be strong, and then there's days that you struggle. So I think it's also just like you said, just culturally, we sometimes
We need to
just don't wanna-
normalize that.
Yes, we don't want to discuss the times that you're not.
Yeah, I really appreciate you say that. And everybody who's ever worked with me as a client or in the peer professional community knows and is my absolute word. I rarely, if ever, use the word but, and I appreciate what you just said there, which is language matters, of course, and narrative matters. So how can we say, like, I know it takes a lot of bravery, it takes a lot of courage, it takes a lot of strength to navigate this. And I know we're in our humanity, we can also feel scared and tired and drained and all the sort of things on the other end. And how can I help bolster that end of what your experience is? And just to name it, the and of it, I think is important. I'm not a huge fan of the word you're strong, like that sort of fighting language. I think that, again, skews us towards avoiding our vulnerabilities as humans going through this completely abnormal thing that we go through when we're experiencing a cancer journey, or when someone we love is experiencing a cancer journey. Yeah. Jill, not to call on you if you don't want to participate, that's okay, but I'd love to hear.
I loved listening to everyone's, and I apologize for my camera not being on. As you can tell, I'm fighting a bit of allergies, so I have to like keep getting up and all that fun stuff. So I apologize. But I can totally appreciate everything that everyone said. You can't see me, but I am a millennial, so I'm more open to talking about therapy and talking about those kinds of things. And I think it is harder when you look at other generations, and kind of a touch on how Abby said, like, you're strong, and not admitting you need help. And I think it just takes those 5 minutes of being like, but how are you? And I know one of our partners for the solution grants, they do training with, healthcare professionals for them to deal with, everything that's going on in the hospital and everything they see. But I think it could be powerful to implement something like that, of giving them the right tools to talk to their patient. And I think it's, it's kind of become a joke at this point when, everything goes wrong. You're like, oh no, I'm fine. Everything's fine. Like laughing about it, but actually digging in. And I can only imagine,
this feels hard, or
yeah. And it's like that constant lingering, like, we see a lot of people that, beat it and, are great, but it's lingering and not knowing stuff. And it's like, it's okay to put a name to it. Like, I'm anxious, that it could come back, or I'm anxious about that stuff. And I think it just, like we've all kind of been talking about, and I don't want to keep, going around and around, but of just taking those 5 minutes to say, no, like, how actually are you? And, I think that's powerful when you said no, but like, where do you feel it in your body? Because our bodies do carry everything with us. And it's when you ask questions and you sit back, you're like, oh, wow, my shoulders are tight, or, that kind of thing. So it's just taking time to be, not just powerful doctors and nurses and everyone like that, but just trying to just communicate on a human level. Like, no, but how are you?
I think we underestimate the power of being human.
Yeah.
As providers and as individuals. I see it again in grief support all the time. People are like, I want to come in, I want to have a solution, I want to fix. I was like, can you just show up and be human and accompany somebody else being human in their frailty? That's the best grief support, or the best support you can give somebody. Yes, there's practical and tactical things we can do, but I think we often in our expert culture try to jump to solution oriented and expertise and fixes. And I think showing up in your humanity is the most important place to start.
Yeah.
Something you said, Jill, just reflected, of course, I'm biased because I use mindfulness and meditation in everything I do. I understand that our bodies keep our emotional world, our bodies definitely keep our trauma histories, for sure. So just helping patients to locate, use that as a tool to kind of locate. But I also think going back upstream is if there's fear or anxiety on the provider's part about the pain they're going to cause this patient, or that they don't have a solution to their emotional, mental well-being, they show up with energy too.
Yeah.
And that has a kind of cascading effect. So I often use this tool. I use in every presentation. I didn't do it to you guys today, but every one-on-one session, I'm about to go give a talk at this conference I'm at, I do an arriving activity. So how do we as providers use our breath, settle into our body awareness so that we shift our energy so that we can be showing up more of as like a space to hold for the patient, as opposed to kind of, kind of unleashing, frankly, whatever our anxiety and our worry and our energy is on the patient. I also think something to what you said, Abby, just resonated for me in the sort of strong language sometimes closes the door. It's that stigmatizing. It sort of closes the door to us revealing our vulnerabilities, the hardships that we face. So even thinking about language that says like, it really takes strength to admit, to ask for help, or to be vulnerable, and just naming that as a provider, I really recognize how much it's a struggle for. You don't have to tell them your personal story. What if you said in one sentence? I know for me, sometimes it's hard to, admit when I need support or I'm being vulnerable, but I think the strongest thing that I've ever had to do is ask for help in that area. Like, how do we, I don't know, embolden sort of asking for help and being vulnerable, or acknowledging whatever our struggles are as something to be proud of, or something that is important, that's something that requires strength, as opposed to something we want to kind of sweep into the corner. Yeah. KK reminded us we have about 25 minutes left. It's just as a framework. We don't have to stay, or we'll have this conversation continuing, but just wondering, when we're thinking about, and KK might help us remember, we're thinking about the potential investments to solve. Is that the language that we're kind of thinking about as our task, our charge today?
Yes. What a potential investment by Livestrong for a mental health solution. What could that look like? And what are some of those ideas that could be implemented in real time, big or small?
Okay. Yeah. So when we're thinking about all the conversations, including like Srini, who had to leave, and Simon, I know Heather didn't get a chance, but when we're thinking about some of the conversations we had today, are there particular domains or areas? I've already made pretty clear what my thoughts are on that, but I just want to make and bring other voices back into the room in terms of when we think about an investment, a request for a proposal that Livestrong might put out there, to think about piloting some way that we might begin to. And I think that's an important framework, because we're expert, tackle, solve problem kind of culture kind of people. And I think we just need to name that no one investment or two investment is going to quote unquote solve the challenge of poor mental health care and cancer care. And we have to start somewhere. So thinking about that as the kind of framework for the folks that are still in the room, is there places where you think might be a good first, a place where we might consider beginning?
Something that I thought was interesting, and we just talked about it, and you mentioned it at the very beginning, Lisa, was this concept of flipping the me to a we, and how when you're newly diagnosed, or honestly even a little farther down the road, you walk in the room and you feel like you're the only one going through that scenario.
Yeah.
And sometimes that is reinforced, like you said, by doctor language, or just how you're feeling that day. And I think we honestly wait too long to help flip that script. Like, we don't mention peer support. We don't mention social emotional support until we are in treatment sometimes, or even after treatment. Like, I know a lot of people that we've talked to at Livestrong have said after the fact, they would have really liked to have been peer matched early on. Yeah. Or they would have really, as Nick mentioned, like, would have really enjoyed having like a support group much earlier in the journey. So I'm just thinking, like, is there an organization, or is there a hub, or is there something that we can create that can have a place for people to go to much sooner? And can we get that into people's hands? Because sometimes it is hard to make that phone call, or sometimes, it is hard. And I feel like people get hung up on, I need a breast cancer support group for older women. But sometimes you just need to talk to someone. So it doesn't have to be super specific, I think. So what is something we can bring to the table? I feel like that it's in reach. I don't know quite what it is.
Well, I think, you're talking about the delivery of some kind of support or certain resource. And I think that's really important. I think, though, where you started, I think is equally important. So there's that flipping the me to we, because nothing makes us feel more isolated and alone and othered than having that kind of experience. So even the doctor sort of naming, there are other people who have been through this, we have resources. And I would add it even a step further for the doctor to be, or a nurse or whoever, just the provider, I should say that word, the provider to do the we. Like, I know you might even disclose, you're not telling any personal stuff, but like you might disclose, I know when I faced this, or I know when I had a family member face this, this was something that they wanted to go through. A sentence, you don't need to tell them your personal story, but just to level that playing field of power, but also to bring that person back into community because they feel so othered and so different and so isolated from their diagnosis, or the caregiver too. And to flip that me to we, that language and that kind of training from the provider standpoint, and that kind of language, just marketing kind of culturally, back to Srini's point, I think is an important place to start. Then the delivery of resource, like this kind of peer matching kind of situation, is much more likely to be taken up by the patient because they've been established as, oh, this is something that happens to all of us when we navigate this cancer journey. I mean, there is in Austin regarding cancer, which does, peer matching. So there are in the Austin community doing that. But as to what Nick said, like, some people aren't going to want to do a peer group, or some people want to be in a group. They don't want to do one-on-one. Some people just might want resources. So I think switching the me to we starts with the provider's own beliefs, and then how the provider communicates in those sessions. And then there's the resource delivery, which, by the way, those conversations have to be ongoing, because there might be at the first chemo treatment, you don't even want to think about that, but it might switch really quickly. And by the second or third, if that provider asked that question again and said, we all go through this and sometimes it can be challenging, and I'm just reaching out to you to say, I wonder if that would be helpful. That's important. We can't just, I asked them the one time, because the evolution of somebody's experience of feeling othered in their cancer journey is, changes over time, of course. So I don't know if that added to or diluted what you were trying to say, but I appreciate the sort of me to we idea, and having that be the position from which we offer resources for people to be and connect with patients like them. And I agree, it's not necessarily brain cancer to brain cancer. It might be the progression of disease. It might be language or cultural or just location, physical location. I just want to talk to another cancer patient in the east side of Austin because we face challenges over here. I'm just picking that as an example. Yeah.
So I know that there's probably, I'm going to say hundreds of probably groups, I'll say, that are out there for support. Okay, which I've found over the years.
Yeah.
Okay. Either on Facebook, there's a group of support of women in the Wilmington, Philadelphia area and they just basically talk, or they get together for coffee or whatever. I really haven't connected with them because it's more of a women's breast cancer thing, but I'd like to be involved, just to see what's going on. And I know there's a startup near me that's kind of pushing in that way. It's kind of I want to call it a mini comm model that we have going on at the Dell Cancer Center, where it's a small community house, not a community house, but I guess it's a house that they converted into. It's going to be, they have yoga, they have acupuncture, they have all kinds of stuff, and addressing mental health too.
And the whole care.
Not necessarily the medical part of it, but the rest of it, let's say.
Yeah.
Okay. Well, those things are there, but unless you start going, once you're diagnosed, then it usually takes maybe a year or maybe afterwards where you really realize, hey, there is a couple of places near me where I can go to get that help. So how do you get that? I guess what we're talking about here is, how do you get the provider, the doctor, the oncologist to say, hey, here's a list of providers in your area that do this kind of thing,
And then check in again, like
Yeah,
moving it
exactly.
upstream on the
Yeah.
early, like, because you might, I don't know about you all, but when I got lists of things, I mean, it was very short between diagnosis and surgery and coma and death, but they gave me a list of things and I was like, okay, I can't.
Yeah.
But if a doctor then said, when I was standing over his bedside, have you thought about, remember that list? Have you thought about that? I know a patient recently liked XYZ group, with it. Is there a way I can help you get a hold of them? Do you want to try that? So like continuing to check in, because
And not only for the patient, like you just said, your husband passed and you were just out there, right?
And I was the clinical director of a major nonprofit social, I was the social worker at a major agency in my town that I was living in. And so I was able to, because I had referred millions of families to the resources that I ended up using for my daughter, who was 7 at the time when my husband died. But, I knew that only because of the position that I had in the community, but I wouldn't have known that, if I was somebody else. And it still took me some time and somebody, a friend saying like, have you, and I have my own hangups, even as a provider, about, I provide help. Can I go ask for help? I don't know if I can,
Sure.
do that. So
and the one thing, like when my dad was sick, he was friends with a neurologist who helped him quite a bit. And he was friends with my mom and dad. So in his own way, he would just stop. And my mom, even after my dad passed, or if my mom was home, he would stop at the house, just talk to her.
Yeah.
You know what I mean? But that was something that just because we knew him, but not because of anything else, It wasn't like the oncologist for my dad said, oh, here's somebody that can.
It might be helpful to have someone to check in and talk to over time.
Exactly. So
it comes back to me. I mean, I always think about, I know we always want practical solutions, and I want it, and I know we're going there, but I think we can't jump to practical solutions until we tackle the beliefs. And I think we have to go upstream to those beliefs about it's how are we showing up in our whole humanity as systems of care, as providers, for the full humanity of the patient that's in front of us. And the full humanity of the patient that is in front of us is not just the eradication of their cancer. And so I think, certain systems of care have learned how to, they have the list and they pass it out, et cetera. But if we don't actually have the ingrained belief that that's actually something that's just as valuable as tracking the radiation course of treatment or the surgical course of treatment or the right, those treatments, then it's not going to become more, it's not going to have the effect that we want. It's just going to be a one-off thing that goes to the side. So we've got to really do some of that sort of cultural and training at kind of the bigger level to help people understand that is just as critical a part of cancer care as any other aspect of cancer care.
So where does that start, in medical school?
Yeah, I mean, I have to say, I think it does. I have thankfully been invited recently to go talk with the residents at Baylor College of Medicine. I've done a couple of workshops on empathy in patient care. And part of what I've been talking about is before you jump into solutions or using your expertise to explain, are you showing up in your full humanity, understanding that they're showing up in a stress response in their full humanity? And how is that changing the way you might deliver care? I mean, I think it's again, I don't think there's one silver bullet. We have to stop getting hooked on our culture that thinks we can just check a top 5 list and we're going to be cured. But I do think it starts at the educational level. I really do think if we changed a cohort of providers, upcoming providers, that would be a huge place to start. I think it's worth talking to existing providers. I think they have look, providers want to be doing well. They wouldn't be in this profession if they didn't want to be helping their patient. It's just between the systemic constraints and their own training, this isn't an aspect that has given the kind of privilege that solving, surgical solutions have given.
Yeah.
I do think kind of upstream to the provider education and supports is is a place to do that. Because as you said, there's a lot of providers out there, not that there shouldn't be more there, but there's a lot of yoga places and mindfulness places and therapy and support groups. But patients aren't going to feel comfortable and safe and have access to those things if it doesn't start further upstream.
So KK, we do Livestrong at school, right? For kids. Why don't we do Livestrong at medical school?
That is a tall task.
I know.
I'll put it
Pilot
on my
it.
to-do
I
list.
already have a relationship with Baylor College of Medicine if you want some help.
But you got to start somewhere.
Or
right?
Dell, we can do it at Dell Med.
Yeah, and I'm a UT Health alum, so there is hope. I won't say no, Nick. I won't say no to you.
No, I know. It's just a thought. That's all. And I know it's not easy to do, but
none of these are easy. You have to start
none of it was easy when we started the Dell thing either, right?
Yeah.
The COM model and all that. So.
No, exactly.
Yeah.
Yeah. I mean, I remember being around in those conversations when I was running CareBox program back in the day. I remember when we had our first meetings at the Institute about what would the COM model look like. And now it's being, enacted and it's being adapted and learning as we go. Robin and Becca and all those folks.
And I'll tell you, it's not fast enough getting out there.
I know it's not fast enough. I mean, I agree. And like we said, that's why I wanted to frame this, even though we're coming towards trying to think about what might be one potential investment, which, is an important thing to come to. I think just like we're asking doctors and providers to shift their perspective on what matters, I think we have to shift our own perspective. And it's like, what's the next best thing we can do? That's a question I always ask myself when I feel overwhelmed in solving a problem, right? And I think we can apply that to this task that we have in front of us. Like, what might be the next best thing? It's not going to be the thing. And we can let ourselves off the hook that it's not going to be the thing. But what could be the next best thing? I think that's a place to start.
That makes me think of we don't necessarily need survivors to talk to newly diagnosed people. Maybe we just need people to talk to people who've been recently diagnosed. Maybe that's the lower hanging fruit in this situation.
I think so. People want to be heard. We all want to be seen. I mean, again, I've just come from this is my, graduate thesis. This is my life's mission, is really bearing witness and holding space practices. Part of what our anxiety, our depression, our fear, all of our experiences is we aren't heard. We aren't really seen. We don't feel safe to be seen. And so I do think, yes, it would be ideal or be great if somebody was further down that particular, treatment plan, course or whatever, to talk to them. Yes, there would be some insights there, but I think there's something about connecting humans with other humans and being able to be seen and held in their hope, in their fear, in their anxiety, in their the full spectrum of whatever their mental, emotional, psychological experiences of their cancer journey.
Right after my dad passed away, my mom started volunteering at the hospital. And one of her things that she always told me, she would just walk down to the chemo or radiation waiting room. And my mom's a very friendly person. So she would just look at somebody and say, hey, is everything okay? And then she would just sit down and talk to them for 15 minutes, and they would just, empty themselves out onto her, which was fine. She didn't care at all. But what you just said is just, sometimes you just want somebody to listen to you and to verbalize those words that might just help them for that day. But, who knows?
I really think that showing up and holding space for people is undervalued. And I don't know how we would, if we needed to study or measure that in the metrics. That's been a research question I've had for a long time, actually.
Yeah.
Which is, what is the therapeutic value? And I don't mean therapeutic just in the mental space, but when someone holds on to their anxiety or their fear or their worries, there is a real embodied impact that has on that patient. So how can we think, and their willingness to participate in courses of treatment, et cetera. So I do think thinking about tracking and starting to understand what is the experience of someone who just feels held in their experience in that moment. What would the power of that be? I think anecdotally, I think that from my work over the years, has a huge impact. And when a patient or a caregiver could set that down for 15 minutes with your mom, just kind of, my dad calls it verbal vomiting sometimes when people do that. It's gross. But anyways, when someone can just really set down all that's on their mind and their heart, think about when you've done that. I always invite people to think about your own experience. The other person didn't have to have a solution to what you were putting down. It was just the act of them holding it without judgment. And then you had I almost picture it physically. It's like you had all that stuff here, and you spend 15 minutes putting it down to somebody who looked you in the eyes, who wasn't fearful of what you were saying, who held it without judgment. And now you've got all this space here to think about, okay, well, now that I put all that out in the world, what do I want to do for myself? How do I want to care for myself? What is the next step? What are my preferred outcomes?
Yeah.
But we can't even see that when it's all just sitting kind of locked into ourselves. So that doesn't have to be therapy. Yes, come to me or somebody like that.
Yeah.
Great. But that could just be a human showing up and holding space and bearing witness to another human.
Yeah.
What if that's what we invested in?
I think one thing, sorry.
No.
One thing that comes to mind to me specifically is, when I have a question, whatever it may be, my go-to is, Google, whatever I'm looking for, you name it. And I feel like maybe this is something that lives maybe with the Cancer Market Network, or I'm not sure where I'm necessarily trying to place this, but I feel like just kind of having a place to ask, or filter through a app or whatever it may be, something virtually to where you can say, maybe today I just want to have an online discussion. Maybe today I want to do a video chat. Maybe today I want to meet someone in my area to have, coffee. Maybe today I just want to read some motivational quotes that may apply to someone that's struggling.
I do think a digital marketplace or some technological world, we certainly learned through the pandemic. I mean, I see all of my clients like this, and I actually think we have more effect than them having to drive somewhere and go do something. So I do think, having something digital and something kind of on demand that isn't necessary, they could have a full range of things, not necessarily just therapy, but literally, can I, Lisa, connect with Nick? Because I just really need someone to just hold space for me because I just got the next news about my course of treatment or whatever my thing is. So I think using that digital space, but making it human centered.
Yes.
I think is the opportunity. I'm not going to call it a challenge. That's the opportunity. Yeah.
I think also just having the options too. I think with the pandemic, we've learned that, we want options, for working out. I have an app. Do I want to do does that mean just walking and listening to, whatever it may be, or do I want to meditate? Just kind of having so many options for whatever needs need to be met that day, or that struggle, or whatever it may be. I think that's always, especially for, granted, it might not be as helpful for people that aren't that technically,
Yeah, I agree. I'm mindful that we have less than 5 minutes left. So I want to invite Jill if there's anything else that you want to participate in, and then just ask KK how we might close out today. But Jill, is there anything else you wanted to add in terms of thinking about what might be that next best thing or that potential investment?
Yeah, also, sorry, I realized y'all can't see me like nodding. Everyone has brought up phenomenal points, and it's just so great to kind of be like a fly on the wall in this conversation. And it definitely brings up a lot of valid points, but I really did like KK's like, flipping that me to we, because I think it is interesting. And I think giving people, that opportunity before the after, like, okay, your cancer free, like now what? And giving those resources kind of at the beginning, because I think people need to talk about it like no matter what. And it's just kind of like everyone said, sorry to like, keep repeating everyone, but kind of just being human. It doesn't mean you have to go to therapy. It doesn't mean you have to be mindful, but just asking simple questions, because not everyone's open to therapy or anything like that. It's just, and when KK, you did say like meetup, like groups, I thought of like, meetup.com or whatever. I don't know if there's anything like that, but I really did like Nick's idea as well as, Livestrong at medical school. So I know that's a big bite, but I think that was a great point. And it is hard because, and there's nothing against, anyone in the medical field. They're doing as much as they can, trying to see as many people as they can. But it's just trying to bridge those gaps again. But I really appreciate everyone's opinions, and it really has been great just to kind of be like a fly on the wall.
Thank you.
So
I'm
thanks.
glad you've been participating. I mean, I think we heard there's kind of the almost, if I might just, I'm kind of distilling kind of what we were just talking about. I'm just throwing this out there. There's kind of almost the marketing or the kind of language and communicating, which is, I'm almost picturing a visual. I'm a dream, like on the side, I want to do like graphic design and marketing, but I'm picturing like changing the M to a W, like from a me to a we. Like, how do we shift kind of that we show up? We are all humans showing up in this thing. That's one, which is more maybe like that's a task that could be one investment. I think the second is, and naming my bias right from the start, is kind of how do we upstream medical education and training so that we can shift that belief system and those practices. That's maybe a second. And the third is maybe something more around how do we explore a kind of human to human digital space so that people have ongoing access to feeling heard and seen in their experience. I don't know if I did that, but I was trying to, even though we can't really sum everything up and solve every problem, I was trying to kind of wrap everything up in a package. And I feel like those were kind of the three domains that we kind of collectively landed on, but also happy to be called on it in the last 2 minutes.
I definitely was picturing that, like me to we, and how do we do like a little flip. So I'm really glad you said something like that.
Yeah. KK, I'm mindful of our time. So what can this group expect after now, and just help us close out today?
Sure. Well, first off, thank you, Lisa, for running this session. I think we really appreciate your all-encompassing viewpoint of this topic, both from your personal story as well as your current work. I think everyone did a great job of sharing today. That's what really makes innovation conversations work.
Yeah.
Whether it's a small idea or a big idea, there are no rights and wrongs. So thanks so much to everyone for participating today. I agree that we've highlighted the solutions we would like to see, flipping the me to we. How do we convene all these resources that we have and get them in people's hands, changing the culture of conversation about mental health and all those other aspects. We didn't talk about what we shouldn't do, but I think we did along the way. So no need to end on a negative, in my opinion. And ideas that can be implemented in real time. We do have Livestrong kind of inching towards some of these things we talked about today. But of course, working with different community leaders to actually get these changes implemented, I think will be a necessary step, regardless of if it's Texas or Pennsylvania or San Diego, where Lisa is today. Yeah, thank you so much to everyone for participating. Livestrong will definitely take this information back and see if there is something we can do in the future in the mental health space. Yeah. But yeah, any final words, Lisa, before I close the meeting?
Just thank you, like as one human, to all of you humans in the room watching this live, or if you're watching this later. I just really appreciate, I think this is the juice. I don't want any of us to forget that it really just takes people who care showing up for other people who care to think about how we shift systems. And we don't have to have necessarily the resources or power of providers or institutions, even like Livestrong, but it takes us all showing up. So I just want to thank you from one human to another, to everybody for showing up and caring and bringing your wisdom and your lived experience to the conversation today. And thanks for having me to Livestrong.